Good afternoon, everyone, and welcome to the Assembly Committee on Health and Human Services. I remind our members to please mute your microphone when you are not speaking and try to remember to unmute it when you do want to speak. Also, please leave your camera on so we can make sure that we are maintaining a quorum. Madam Secretary, will you please call the roll?
Assemblywoman Benitez Thompson, Assemblywoman Black, Assemblywoman Gorlow,
Here.
Assemblyman Hafen,
Here.
Assemblywoman Krasner,
Here.
Assemblyman Matthews,
Here.
Assemblyman Orentlicker,
Here.
Assemblywoman Peters,
Here.
Assemblywoman Summers Armstrong,
Here.
Assemblywoman Thomas,
Here.
Assemblywoman Titus,
Here.
Chair Wynn.
Here. It looks like if we can mark Assemblywoman Benitez Thompson present when she arrives. Additionally, I see Assemblywoman Black. I didn't hear her say yes or no, but once she arrives and turns on her monitor, if we can mark her present as well. Thank you to everyone in our audience joining us on this virtual hearing this afternoon. We have two bills today, and I am just going to get right into it. I would remind everyone that at the end of the hearing, there will be an opportunity for members to ask questions, as well as we will be able to take comments from the public in support, opposition, and neutral of both of the bills that are being presented. And at this time, I will open the hearing on Assembly Bill 216. This bill requires Medicaid to cover certain services for people with cognitive impairments, and we will turn it over to our own Assembly member, Assemblywoman Gorlow, to begin when you are ready.
Thank you, and good afternoon, Madam Chair and members of the committee. For the record, I am Michelle Gorlow, representing Assembly District 35 in Clark County. I am pleased to be here today to co-present Assembly Bill 216 for your consideration. I am joined by officials from the Aging and Disability Services Division and a member of the Nevada Commission on Aging, who will provide technical information on the bill and discuss a friendly amendment offered by the division. Assembly Bill 216 was recommended to the Legislative Committee on Senior Citizens, Veterans, and Adults with Special Needs during the 2019 to 2020 interim session. The bill mandates that the state plan for Medicaid include coverage for cognitive assessments and care planning services provided to persons with symptoms of cognitive impairment. Believe it or not, Alzheimer's disease is the single most expensive disease in the United States, outpacing the cost of cancer and heart disease. An analysis by the Alzheimer's Association calculated that the direct cost posed to caregivers totaled $305 billion in 2020 alone. They also estimated that Medicare and Medicaid covered 67% of the total cost. There are a host of early interventions and detection strategies that can stave off astronomical expenses associated with late-stage dementia and Alzheimer's. In fact, the Milken Institute released a report showing that early diagnosis in the mild cognitive impairment stage could create cost savings as much as $7.9 trillion in U.S. health and long-term care expenditures by enabling better planning, management, and care. The Centers for Medicaid and Medicare Services cover cognitive evaluation and care planning for Medicare recipients. In 2018, CMS added current procedural code 99483 to pay physicians an average of $242 to perform early intervention treatments. Unfortunately, Medicaid does not offer the same coverage. AB 216 seeks to provide these life-saving services to Medicaid recipients. By funding assessments and care planning, we can get ahead of cognitive decline to ensure those suffering and their caregivers can manage the devastating effects of cognitive impairment. As introduced, AB 216 would require the state plan for Medicaid to cover the non-federal share for cognitive assessment and care planning services for persons with cognitive impairment symptoms. For families with members who have Alzheimer's, this bill will ensure support services are in place as the disease progresses. This type of advanced care planning can prevent acute hospitalizations, which can be traumatic for individuals and their families, as well as generate unnecessary expenses to the healthcare system. I will now hand it over to Aging and Disability Service Division to discuss the need further and present their amendment.
Good afternoon, everyone. This is Gina Schmidt with Aging and Disability Services Division. And thank you for hearing this bill today. We did just offer just a couple small amendments to make minor changes. I'll walk through those and then I'll turn it over to Mary Liberati, one of our Commission on Aging board members, to walk you through the bill. The amendment is pretty minor. In section 1, number 1, just replaces the words "who exhibits" with "experiencing the." The change just ensures language would not preclude anybody who was self-reporting from receiving this particular service. In section 1, number 2, changes in this section are just meant to align the definition of cognitive impairment with medical terminologies. And so that is removing D, judgment, as it relates to safety awareness. And also in section 2, add "or" between areas of deficiencies to clarify that someone could have any one or all of these deficiencies. So really they were just minor cleanup language. And with that, I'm happy to turn it over to Mary Liberati, our Commission on Aging member.
Good afternoon, Chairman Ewan and members of the committee. My name is Mary Liberati. I am a retired social worker and I serve on the Nevada Commission on Aging Services. But actually, sorry, it's the Nevada Commission on Aging. I also sit on the Alzheimer's Association board of Northern California, Northern Nevada, but today I will only be speaking on behalf of the Nevada Commission on Aging. As you've already heard, it's vitally important that people have access to early detection and care planning. So I wanted to just hit a few high notes that you may know already, but if you don't, for the record, dementia is not just a disease for older people and seniors. It's normally associated with those over 65, but the Alzheimer's Association estimates that 5% of those with dementia are younger onset form, and that currently there are approximately 200,000 people across the United States that have the younger onset form. According to data from the Nevada Department of Healthcare Financing and Policy, known as Nevada Medicaid, between state fiscal year 2016 and 2020, 4,374 individuals under 65 had a diagnosis of dementia or Alzheimer's disease that were already in the Medicaid program. And they estimate approximately 730 people per year will be diagnosed that are on Medicaid. So how prevalent is cognitive decline in Nevadans under 65? Well, according to a 2015 survey conducted by the Nevada Department of Health and Human Services, it showed that 16%, or 1 in 6, Nevadans aged 45 to 64 reported worsening confusion or memory loss. We call that subjective cognitive decline, or SCD. It's a condition associated with later development of dementia, but nearly half of these individuals have not talked with a healthcare professional about their concerns. Not all who experience or report SCD go on to develop dementia or need a comprehensive service. But a review of pertinent research conducted by the graduate students at the UNR Sanford Center on Aging found that between 5 and 8% of those who report SCD go on to develop mild cognitive decline or dementia. So it's so important that we have that early and accurate diagnosis for younger onset dementia, because we know that it affects their work, their finances, and their family. But an early accurate diagnosis is crucial to rule out other potentially treatable conditions and to get the most appropriate treatment early in the disease process. My own personal experience is that my father one night believed there were intruders in his home. He called the police showed up, and then he didn't believe that they were the police. So we had to have a trusted neighbor come over and convince my father that it really was the police. As it turned out, of course, there was no intruder in the house. However, I got called that evening, and I immediately called a friend of mine with the Alzheimer's Association, and he said, Mary, dementia does not come on suddenly. It's a gradual process in most cases for Alzheimer's disease, although some dementias may have a more quick progression. So she said, Mary, you've got to get your dad to the doctor. We got my dad to the doctor, The doctor ran some tests and we found out that my dad had a urinary tract infection that was causing his confusion. So as soon as he was able to get the medicine and to get hydrated again, he was able to, the confusion went away. So it's so important that we know that, because sometimes dementia, confusion appears to be dementia, and it may not be. Early and accurate diagnosis can also give the patient and their family more time to make important decisions about financial and legal issues. It allows the individual time to work with their employer on work accommodations, disability coverage, or early retirement options. In addition, it also allows individuals to apply for disability insurance and supplemental security income benefits from the Social Security Administration. And of vital importance, it allows individuals across the country to access critical clinical trials that we know research is the only thing that we're going to find, the only thing that will help us find a cure for this terrible disease. We've already mentioned in the hearings about the code 99483. What that does is, and what this bill would do is enable physicians to use that code, which is an important tool in the diagnosis of Alzheimer's disease and other dementias. With this code, clinicians have the time to do thorough evaluations of the patient's cognition, and also to provide a comprehensive set of care planning services to people with cognitive decline and their caregivers. This billing code was added to Medicare and TRICARE programs in 2018, as Assemblywoman Gorlow had also already mentioned. Other states are using this code. There are 16 other state Medicaid programs that are currently using that code in their states. As we said, it's so important that this could prevent future cost, it could provide future cost savings and prevent high cost in Medicaid and our other healthcare services. The Social Security Administration has added younger onset Alzheimer's to the list of conditions under the Compassionate Allowance Initiative, which means that gives those with this disease expedited access to not only Social Disability Insurance, SSDI, but also Supplemental Security Income, SSI. This can lead to significant cost savings for Nevada Medicaid. After a 2-year waiting period, individuals on SSI can become eligible for Medicare, and this shifts medical costs from Nevada Medicaid to the fully federal funded Medicare program. And we believe that will lead to savings in Nevada in future biennia. Thank you for your time today, and thank you for considering this important piece of legislation for our families with younger onset dementia. Thank you, and if there's any questions, I think we're going to do it at the end, but thank you for letting me be here today.
Assemblywoman Gorlow, do you have any other people presenting with you this afternoon?
I do believe we have somebody from the Alzheimer's Association that is also going to be speaking, a Ms. Nikki Rubarth. I was looking to see if I saw her in the gallery view.
I see her on the Zoom. Go ahead, Ms. Rubarth, when you're ready.
Thank you. Thank you, Chair Wynne. Thank you, Assemblywoman Gorlow, and thank you to the committee. My name is Nikki Rubarth. I am the Regional Director with the Alzheimer's Association here in Northern Nevada. And on behalf of the 49,000 Nevadans over the age of 65 who are already living with Alzheimer's disease, we thank you all so much for your time here today and for your consideration of AB 216. The vast majority of Nevadans impacted today are women, and a disproportionate number are people of color. I would like to share some findings from the current Alzheimer's Association Facts and Figures report and outline the importance of diagnosing younger onset Alzheimer's disease, as well as the value of care planning and the ways we envisage this legislation will help bring about cost savings. We know there is a modest financial cost associated with this request. However, according to the Genworth Cost of Care Survey of 2019, the average cost for a 1-year stay in a memory care setting in Nevada is estimated at $51,000. And the cost for nursing home placement for the same period of time is estimated at $127,000. If detailed care plans can take place at the appropriate time, we know we can help individuals remain in their homes, avoid unnecessary trips to the ER, reduce hospital stays, and delay institutional placement, thereby avoiding additional costs to the already heavily burdened healthcare and Medicaid systems. Of note, Nevadans with Alzheimer's made 83,300 visits in 2018, and the hospital readmission rate for people with dementia was 25.8%. 1 out of 4 end up right back in the hospital. But prior to discussing care planning, I would like to address the need to diagnose Alzheimer's or other dementia in individuals under the age of 65. As Mary said, nationwide, about 200,000 people know they are living with younger onset disease. Many of them are in their 40s and 50s. They have families, careers, or are even caregivers themselves. Since physicians generally don't look for Alzheimer's disease in younger people, getting an accurate diagnosis can be a long and frustrating process. Ruling out other conditions is important, as is connecting individuals with clinical trials and possible treatments that might help ease symptoms, improve quality of life, and save other healthcare costs. The specific medical billing code indicated in AB 216 gives healthcare professionals sufficient time to address care requirements during the patient visit and put plans in place, the plans that answer the unique needs of a patient with younger onset disease. Those plans can include making connections to services such as those offered by the Alzheimer's Association, workshops and education classes, support groups, early stage engagement programs, and of course, access to respite care. If care planning can happen early on, we can also anticipate a decrease in costs further along in the disease process. In 2020, Nevada Medicaid spent $203 million on caring for people with Alzheimer's, and that number is predicted to grow by 36.5% by 2025. We can't afford to wait until 2025 to look for ways to bring those costs down. This bill starts now. We sometimes hear from people who are living with Alzheimer's or other dementia that they are much more than their diagnosis. And we're urged to look beyond the label to see the vital, vibrant human being they still are. If we can empower people with younger onset disease to make decisions about their own future care needs, including their legal and financial plans, early on in the process, then we could also help preserve their autonomy and relieve a great deal of stress all around. We do not yet know what causes younger onset Alzheimer's disease or how we can stop, slow, or prevent its progression. At the Alzheimer's Association, we continue to invest in research to find answers to those questions. What we do know is that individuals of any age deserve an accurate diagnosis at the earliest opportunity, and that developing detailed care plans can help preserve a quality of life that makes the future look much brighter. Cost savings are only the tip of the iceberg when we think about the many ways that this important bill can help our fellow Nevadans. Thank you again so much for your time and attention to this important issue. We appreciate your support for the passage of AB 216. Thank you. Do you have any questions?
Assemblywoman Gorlow, do you have any other presenters this morning or this afternoon?
I think we have one more that's going to speak on their personal story.
Okay. Do you know who that's next? We'll have that before we have some questions. And I know that we do have a list of questions.
My apologies, I don't have her name handy.
I'm Amy Moore Peterson from Boulder City, Nevada. And thank you for your time and consideration as you listen to my story. I want to introduce you to my husband, Rue. When he celebrated his 47th birthday, he was living the dream as a 737 pilot for a major airline. Excuse me, with a degree in engineering, he owned, restored, and maintained a collection of vintage airplanes. He was an accomplished woodworker. He was an avid reader. In short, he was brilliant. 1 month after his 47th birthday, Drew would surrender his pilot's license, knowing he could no longer fly due to the cognitive decline he was experiencing. I continued teaching for another 3 years, but I never knew what I would come home to. Would it be Dr. Jekyll or Mr. Hyde? The mood swings were increasing and depression was setting in. And he was very good at compensating and hiding his condition. And I knew that Alzheimer's ran in his family, but I never imagined it would present itself in such a young, healthy man. I knew something was terribly wrong when the man who had flown 737s for a living could not figure out how many linear feet of irrigation pipe he was needing. So after numerous doctors, MRIs, scans, tests for heavy metals, STDs, vitamin deficiencies, a DNA blood test confirmed that there was a genetic mutation on the 14th chromosome, and another procedure confirmed elevated levels of the tau protein in his spinal fluid. It was official. He had Alzheimer's disease. They referred to it as APOE-4, which is a rarer form of Alzheimer's that presents itself in younger age onset and also in familial cases. He was only 50 years old. Now, I might note really quickly that Drew's mother was one of 8 children, who 5 of whom developed dementia in their lifetime. Drew's sister died last spring at the age of 69 due to complications of Alzheimer's, and his 68-year-old sister is currently in the middle stages of this disease. Now, after the diagnosis of Alzheimer's, it was a flurry of getting the family trust in order, getting powers of attorney in place, financial considerations for a man who could no longer work, even at the most menial job. And I was unable to return to the classroom because now I was a full-time caregiver. Drew was forced to take a medical retirement 18 years before his planned retirement at 65. He was 47 when he retired. Fortunately, a friend suggested SSI, and it did take a neurologist's diagnosis in writing and numerous psych tests. But he was, SSI was finally approved, and then he became eligible for Medicare. That was about a 4-year process. Drew eventually developed blood clots, both pulmonary and DVT, and was becoming a wanderer and a fall risk. And as a caregiver, I was sleeping with one eye open at all times. I had cracked 2 of my molars. I was experiencing atrial fibrillation. So the last 18 months of Drew's life were spent in a very nice, clean, safe group home. They tended to his every need. They were wonderful, but they did not accept Medicare. So SSI covered about 60% of Drew's monthly care, and the rest was out of pocket. It was a sunny May morning when I held Drew's hand as he took his last breath, and that was 2 weeks after his 58th birthday. So my husband of 30 years was gone, and I was a widow at 55. So now what? Everything happens for a reason, and I've been fortunate enough to volunteer for the Alzheimer's Association in the Desert Southwest chapter for about 5 years now, doing educational presentations and facilitating caregiver support groups. I do one at the Boulder City Senior Center and one at the Southern Nevada Veterans Home. And that's in addition to a biweekly grief group. My story is not unique. The caregivers that I work with repeatedly share similar stories. So I urge you to consider this bill before you, AB 216. It'll make such a difference to the families that are affected by younger age onset Alzheimer's disease or any dementia. It'll make such a difference to have a timely diagnosis and be able to form a care plan. So I want to thank you all for your time, for the opportunity to share my story and to share Drew's story. Thank you.
Thank you, Ms. Peterson, for sharing your story. At this time, Assemblywoman Gorlow, are you ready for questions?
Yes, thank you, Chairwoman. We are ready for questions.
Perfect. And I will note for the record that Assemblywoman Black is present, as is Assemblywoman Benitez Thompson. I know she is having some issues with her camera right now, but I see that she is present. And with that, I will go for our first question with, hold on one second, Assemblywoman Peters.
Thank you so much, Chair. Thank you for your stories and for expressing the importance of providing services for people who either suffer from dementia or their caregivers. I had a kind of two questions, I suppose. The first one is, I'm hoping relatively quick and ties into the second one. My first question is, how many other states have adopted similar coverage under Medicaid? And what existing coverage under Medicaid is there? I think you went a little bit through some of the existing coverage, which is like the farther down the track of the illness. But can you just discuss that a little bit more?
Thank you for the question, Vice Chair Peters. I'm going to have to ask Aging and Disability if they happen to know how many other states have this. If not, we can get you that information.
Dina Schmidt for the record. So currently, the assessment that is allowable under Medicare indicates we have an indication there's about 16 other states that Medicaid covers this service.
And Ms. Schmidt, are you able to answer that follow-up question about what we do kind of cover in this area currently?
So as far as the planning, and we have representatives from the Medicaid division on the call with us to answer those specific questions in case there are, because I'm not familiar with the current services that are covered. I know we don't currently cover this one, but something similar, perhaps we could defer to our Medicaid folks for some help.
Oh, who's going to pop up first? Do we have Mr. Young?
Good afternoon, Chair Gwynn and committee. Dwayne Young, Deputy Administrator for the record. With me today is Aaron Lynch, my Chief over Medical Programs. This CPT code, as far as I know, is fairly unique. And so there are medical assessment codes that would fall under the evaluation and management of an office visit. But this CPT code, as I understand it, and encapsulates not only the assessment, but also the care planning, and is fairly unique. And so there wouldn't be anything comparable other than just the assessment codes under the E&M visit for a medical provider.
Thank you so much for the responses. Having had a family member with dementia related to Parkinson's disease, I can understand how important it is to be able to identify these things early on and get the care and help for the family as well as for the patient. And the more we can do earlier, I think the cost savings is really significant. Thank you so much for the bill.
Thank you for the question.
And up next, we have Assemblywoman Thomas.
Thank you, Madam Chair. And thank you, Assemblywoman Garlow, for bringing this bill forward. I am super appreciative of it because my mom, before she passed, was diagnosed with dementia. And just knowing before the onset, because she had a stroke, and I believe that brought it on, which was amazing to all of us, her 6 children, because there were occasions that she couldn't remember subjects, that if we were talking with her, she couldn't remember names, of course. She would go down the list and then finally would say, when she was calling one of us, well, you know who I'm referring to. So, but we would just take it as, no big issue. And when the onset of the dementia came about, I started asking questions. How many of her siblings? She was one of 10 children, and just about 7 of them had this terrible disease of memory loss. And I wanted to know, my question actually, are the findings related to hereditary? Do we know whether or not this is something that develops in families? Thank you.
Thank you, Assemblywoman Thomas. To you through Chair Nguyen. Yes, we do know that it does run in families. However, I am going to call my friends at Alzheimer's and they'll be able to give you some additional information on causes of Alzheimer's.
Thank you for the question.
You know what? Hold on one second. I can barely hear you, Ms. Rubarth, and Assemblywoman Thomas, maybe if you could mute yours for a second. Why don't you go ahead now, Ms. Rubarth?
Thank you. Is that better? Can you hear me better now?
I can.
Great.
And if you could remember to state your name for the record before you speak.
Yes, this is Nikki Rubarth from the Alzheimer's Association. Yes, there is a significant proportion of people living with Alzheimer's disease who do have a hereditary or a genetic predisposition to develop the disease. That APOE14 that you have heard mentioned here today is one of those genes that might predispose people to developing the disease, 2 copies of that. However, much of the research now is currently around identifying risk factors that might be modifiable, that might reduce people's risks of developing dementia. All of those that we know, a healthy heart leading to a healthy brain, such as good cardiovascular health, a healthy diet, good sleep, plenty of exercise. Those are all factors that might be modifiable and that might be modifiable and might reduce someone's risk of developing the disease. So those are factors to consider too.
Thank you so much. I appreciate that answer. And thank you, Chairwoman Nguyen.
Thank you. And next up, we have Assemblywoman Titus.
Thank you, Madam Chair. And Assemblywoman Gorlo, thank you for bringing this bill forward. You're doing a great job for the health of Nevadans, so I appreciate you sponsoring this bill. I have a couple questions. One, and specifically to the bill itself, and then I have another one if it's okay with the chair. On section 1, it was clarified, and I understand the amendment and the changes, and I looked at that. I just have a question on the definition of short-term or long-term memory loss or orientation to person, place, and time. I've done literally thousands of mental health assessments on folks, especially in the ER. Some folks are impaired. They're impaired because they have alcohol on board, or maybe perhaps a drug on board, perhaps post-concussion syndrome, where they've hit their head and they need to be evaluated for that. And those are questions that I'll ask them, and they don't pass. And so I'm just wondering, is there a time-specific limit on this? Because that can resolve. Maybe it can resolve in a month, a day, 48 hours. They have to do these testing sometimes to participate in sports again after a concussion. Somebody sobers up and they know exactly who they are. They may not know initially or where they are. They probably are oriented to a person, but maybe not the time or place where they are. And so I just need some clarification because I don't see it here, and I don't know if it's defined other where in statute. I understand what you're trying to get to, but there are other cases where they'd fall under that. So is there some clarification there?
Thank you, Assemblywoman Titus. To you through Chair Nguyen. And thank you for that question. You're right, there are a lot of other conditions that can also show some memory lapse. So I think I would need to talk to legal and get their clarification on that. Maybe we need to include that in an amendment. But could legal help?
Unfortunately, we don't have legal on the line because they're busy trying to draft all of our remaining bill draft requests. However, I would encourage you to reach out to legal, and I know we have our policy analyst on here, Patrick, so I'm sure he can also kind of take some notes and see if we can get that message out as well.
Right. Thank you. Thank you for that. Because I think it needs to be clarified to make sure that we are reaching out to the folks that we definitely need to be reaching out to. And I'm very, very supportive of this. As everybody knows, I'm a fiscal conservative on this, and I like the fact that early diagnosis and early intervention will limit and perhaps delay time of admission. Because once they're in the hospital, as was quoted earlier, their costs double pretty much to care of these folks, not only mentioned in quality of life, but a real fiscal note on this. And so I'm very supportive of it. I was wondering if Medicaid, maybe Mr. Young, if you have, or if you don't have it, could get back to us, the number of folks that we have on Medicaid in an extended facility now with the diagnosis of mental impairment or cognitive impairment. Because we have certainly, I've taken care of folks under my, where I was the director of long-term care, and they were there because they qualified for Medicaid and they had some significant mental impairments, maybe not the cognitive impairment definition, because that's what we're changing the CPT code, but they had other mental impairments, such as Alzheimer's. And so do we have any figure how many folks we already have that we're taking care of with that kind of a mental health diagnosis?
Dwayne Young, Deputy Administrator for Medicaid, for the record. Chair Gwen, through you to Assemblywoman Titus. I do not currently have that information. I will get back. I will let you know that our fiscal impact was we looked at, there was data provided to us about 8% of Nevadans are roughly in this cognitive decline. However, we looked at an age range of 55 to 64-year-olds. They would be paid for solely by Medicare after age 65, as you're aware of. And so we looked at a percentage of those adults who were actively seeking doctor's visits and having primary care visits, and then took a percentage of them that might use this test. So we can look at the numbers of those who are actually in our facilities, and if you would so like, we could look at what that would do in terms of the relation of the fiscal note for those individuals if they were caught earlier or the length of time that they've spent in our facility.
Right, and thank you for that. I know this is a policy committee, and I really like the policy. I just feel we need to clarify who we're going to be covering, and then, of course, when it gets into the money committees, we'll need those numbers. So that would be very helpful, Mr. Young. And I thank you, Madam Chair, and again, thank you, Assemblywoman Gerlow, for bringing this forward. And I want to also acknowledge all those who have reached out to me on their personal stories and the ones who testified today. So thank you.
Thank you. I'm looking around. I haven't received any direct messages from any of the individuals on the committee, but if you could wave right now, if you have any further questions. Otherwise, I would love to be able to get to our support testimony on our public lines. And seeing none, I will ask Broadcast Services to get ready to take testimony in support of Assembly Bill 216. I would just like to remind everyone to please clearly state and spell your name and limit your testimony to 2 minutes. We will be timing each speaker. I know that we have quite a few people on the line to testify in support of Assembly Bill 216. So I would encourage you, if there's no problems with saying, yes, me too, I agree, I support this, submitting your statement if it's longer, or your story or your experience in writing. I know that all the members of this committee are very diligent and do review and read all of those. So I would just do that. And with that, we will begin testimony in support of Assembly Bill 216. Broadcast Services, can we have our first caller?
To testify in support of Assembly Bill 216, please press star 9 now to take your place in the queue. Would the caller with the last 3 digits 528 please slowly state and spell your name for the record? You have 2 minutes and may begin.
Yes, good afternoon, Madam Chair, members of the committee. For the For the record, my name is Barry Gold, BARRYGOLD, and I'm the Director of Government Relations for AARP Nevada. AARP has public policy that says we support interventions aimed at preventing or reducing cognitive decline. Think about that, preventing or reducing cognitive decline. You've heard from all the other speakers so far about the costs, the numbers, the people, the planning, the services, all that kind of stuff in the assessments, and that's all great. What I want to talk about is the humanity of this, the human impact. Many years ago, I was a facilitator at the time for one of the very first adult children of Alzheimer's diseases way back when in the state of Arizona. And a lot of the times they would talk about what they called good time or good days. And I want to mention that because I want to expand on what Mrs. Peterson said, and that's we all know someone who have had Alzheimer's. We all have known people that have had other diseases that took them too early. And the question is, not only for the person involved, but for the family members and the caregivers, what would you give to have one more good day, one more good time, one more good day with your family member? Think about that. And with this bill, let's talk about what it does, prevents or reducing cognitive decline. What if you could get 3 months more good time, more good days? What if you get 6 months or a year or 2 years more good days or good time with your loved one? What's that worth? And what would you do for that? So AARP, on behalf of our 345,000 members across the state, strongly support this bill, which will help people get intervention at preventing or reducing cognitive decline to give not only the person, but their family members more good days. Thank you very much.
Thank you for your testimony. Let's go to our next caller in support.
The caller with the last 3 digits, 237, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, my name is Marlene Lockard, Lockard, representing the retired public employees of Nevada. And we greatly support AB 216 today and the testimony given by the bill sponsor and the other presenters. And we think this is a very important legislation and urge your favorable consideration. Thank you.
Thank you for your testimony. If we can go to our next caller in support.
With the caller with the last 3 digits, 261, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, and thank you, Chair and members of the committee. My name is Jillian Block, GILLIAN BLOCK, speaking in support of AB 216 today on behalf of the Coalition of Legal Service Providers. Our attorneys provide the right to counsel for all proposed protected persons in guardianship cases, and we see how AB 216 would be helpful in the context of guardianship. The goal is to avoid guardianship where possible, and assessment and care planning play a role in that. Cognitive assessments are often required to assess whether a client no longer needs a guardian, but often doctors will not perform these assessments because Medicaid doesn't pay for them. I'll share a quick example from an attorney at the Legal Aid Center of Southern Nevada. This attorney had a client who had been under guardianship since 2008. Eventually, this client wanted to challenge that guardianship. Using his own funds, he obtained a new physician's certificate from the same primary care doctor that had originally diagnosed him, indicating that there was now no longer a need for the guardianship. But despite that physician's certificate being enough evidence to place the client in guardianship in the first place, it was not enough to have that guardianship terminated, and the court required a new cognitive evaluation. So this client was required to pay for this new evaluation out of his already dwindling funds. And typically these assessments range from $2,000 to $4,800. So AB 216 would help guardianship clients like this who are required to use their already limited funds to obtain cognitive evaluation when attempting to terminate a guardianship. Thank you.
Thank you for sharing that real life story with us. We can go to our next caller in support.
Chair, there are no more callers in support at this time.
At this time, do we have any callers in opposition to Assembly Bill 216?
To testify in opposition of Assembly Bill 216, please press *9 now to take your place in the queue. There are no callers in opposition at this time.
And do we have any callers in neutral at this time?
Testify in neutral on Assembly Bill 216. Please press *9 now to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you. And I know that we had, do we have anyone on the Zoom? I don't know if I don't believe we already heard the presentation, but.
I'm here, Chair.
Oh, there. Thank you, Mr. Young. Did you want to present in neutral or testify
yes,
in neutral? Go ahead when you're ready.
Chair Gwen and committee, again, Dwayne Young, Deputy Administrator for the Division of Healthcare Financing and Policy. With me today in support is Aaron Lynch, Chief of Medical Programs. So many of this was addressed earlier, so I will just surmise that this is adding one CPT code, that is the assessment and the care planning. It would be added to physicians, advanced practicing registered nurses, and physician assistants. Anytime that we add a CPT code or a service, there is a fiscal note. As Minority Leader Titus pointed out, there is some long-term savings from catching this early, so we will go back and take that into consideration. But this fiscal note is around $900,000 over the biennium total computable. But we are happy to continue working with the sponsor and all of the legislators to get you that information.
And do we have anyone else that's on the Zoom call to testify in neutral? Okay, with that, I will turn it back over to Assemblywoman Gorlow for any closing remarks.
Thank you, Chairwoman. For the record, Assemblywoman Michelle Gorlow. I want to thank everybody who presented today and shared their stories. As was mentioned, we all have family and friends who have had dementia or Alzheimer's. And as a member of the Interim Committee on Senior Citizens, Veterans, and Adults with Special Needs, I'm glad to see this measure is being heard. It's critical that persons with cognitive impairment symptoms and their families access health services as soon as possible. AB 216 delivers much needed support to Medicaid recipients with a life-changing disease. I would like to take a moment and make a shameless plug that for the last 4 years, I have walked at the Alzheimer's Walk, and it will be again in October for those who would like to join me or start their own team. And I urge everyone to support AB 216.
Thank you, Assemblywoman Gorlow, and thank you to the presenters that took time to share their stories. I know often they are personal, but that is what we are here to hear, and I think it is very effective and impactful on the decisions that we're making in this committee. So with that, I will close the hearing on Assembly Bill 216, and I will open the hearing on Assembly Bill 217, which requires training for unlicensed caregivers at certain facilities. And welcome back, Assemblywoman Cohen. I'm sure she's going to get sick of us. We know that she did a lot of work during the interim on a lot of these healthcare-related policies and issues. So welcome back, and begin when you are ready.
Thank you, Madam Chair. For the record, I'm Leslie Cohen, representing Assembly District 29 in Henderson and Clark County. I'm here today to present Assembly Bill 217 for your consideration. This bill is sponsored by the Legislative Committee on Healthcare, which, as you heard, I chaired during the 2019-2020 interim. And it is the result of a study required by AB 131 of the 2019 legislative session. The bill required the committee to examine issues related to training for non-medical caregivers who provide care at certain facilities, compare training standards, and determine whether certain unlicensed employees and contractors should be required to complete a minimum amount of training. Our study specifically addressed training for unlicensed staff who provide care to clients and patients in non-medical facilities, such as assisted living facilities and community-based living arrangements, as well as unlicensed individuals who work in medical facilities. These individuals provide a range of services, from helping with medication administration to assisting with activities of daily living, like helping with bathing, lifting people, eating, helping people eat, and beyond. The key is that they are unlicensed. So for instance, we're not talking about nurses or certified nursing assistants, dietitians, or registered physical therapists, or again, other people who are licensed. The AB 131 study built off of a 2017-2018 study by the Legislative Committee on Seniors, Citizens, Veterans, and Adults with Special Needs, which considered many of the same issues. It found that some of the biggest issues that could be resolved with training related to sterilization procedures, sanitation, infection control, and appropriate care and treatment. The AB 131 study was also influenced by Nevada's experience during the COVID-19 pandemic. According to the Department of Health and Human Services, DHHS, the top 3 causes of COVID-19 outbreaks in skilled nursing facilities in Nevada were 1, inappropriate use of personal protective equipment, 2, breaches and isolation of infections of COVID-19, and 3, hand hygiene and hand washing. Both the 2017 to 2018 study and the COVID-19 pandemic emphasized the need for additional and reinforced training on standard infection prevention and control and the proper use of personal protective equipment, among other issues. Based on this and other supporting information, the committee's final recommendation was developed with input from officials from the Division of Public and Behavioral Health, or DPBH, which is responsible for regulating these facilities. We ultimately decided that the best way to ensure unlicensed caregivers receive appropriate training is to have the State Board of Health adopt regulations prescribing these requirements. This will allow training requirements to be more flexible and nimble than if they were established in legislation. It will also allow the State Board of Health to revise requirements as new issues emerge. So let's go through what AB 217 does. It requires the State Board of Health to adopt regulations prescribing mandatory training for unlicensed caregivers who provide care at certain medical facilities, facilities for the dependent, and facilities licensed under NRS 449.030. This essentially includes facilities, homes, agencies, and providers licensed under Chapter 449 of NRS. It does not include care provided in individuals' homes or in other places that are not licensed by DPBH. The regulations must designate the type of facilities to which training requirements apply and establish the required topics of training, which must include, at a minimum, control of infectious diseases. The State Board of Health must also review the required topics of training at least annually and revise them as necessary to address new issues that affect the health and safety of individuals at the designated facilities. Subsection 2 of Section 1 requires DPBH to post a list of free, nationally recognized organizations that provide evidence-based training for caregivers that may be used to satisfy the training requirements developed by the State Board of Health. Subsection 3 of Section 1 requires the person in charge of a facility to which the training regulations apply to ensure that each unlicensed caregiver at the facility completes the required training and document the completion of the person's personnel file, ensure that best practices taught in the training are implemented at the facility, develop a plan for the control of infectious diseases at the facility and update it annually, and provide a written copy of the plan to every resident, employee, independent contractor, or other person who regularly provides services at the facility. Sections 2 through 18 of the bill make conforming changes, and Section 19 provides that while the bill is effective upon passage and approval for the purposes of adopting regulations and performing other administrative tasks, the requirements with which the facilities must comply are not effective until January 1st, 2022. With us is Margot Chappell, the Deputy Administrator, Regulatory and Planning Services, the Division of Public and Behavioral Health. And before we take questions, Madam Chair, if it's all right with you, I'd like to have Deputy Administrator Chappell provide her testimony for the committee.
No, that would be fine. Go ahead, Ms. Chappell, when you're ready.
Thank you, Chair Wynn and members of the committee. For the record, my name is Margot Chappell from the Division of Public and Behavioral Health, as the Assemblywoman introduced me. Thank you for this opportunity to testify before the committee. The goal of AB 217 is to prescribe mandatory trainings through regulations for unlicensed caregivers in designated medical facilities, facilities for the dependent, and facilities licensed pursuant to NRS 449.0303 that are available for free or minimal cost from a nationally recognized organization. that provides evidence-based training. While reviewing statements of deficiency during the pandemic, we saw ancillary staff such as kitchen staff and those cleaning who didn't appear to understand the importance of wearing a mask or keeping contaminated cleaning cloths, for example, separated from clean ones. Although these are required trainings and statutes, although there are required trainings and statutes and regulations for unlicensed caregivers, depending on the types of services they're providing, the COVID-19 pandemic revealed a lack of knowledge in infection control and prevention by unlicensed caregivers. Therefore, infection control and prevention training would be the focus in the development of the initial regulations. So that's what the bill is trying to accomplish. The topics will then be reviewed annually and revised as necessary to address new issues that impact the health and safety at designated facilities annually. Requiring evidence-based training will help ensure that the information provided in the trainings will be effective. For example, evidence-based infection control and prevention measures have been shown to prevent and control the spread of the disease. And I will just mention that the Centers for Disease Control have developed some really good ones during the pandemic. In addition, the bill proposes to carry this out in an efficient and cost-effective manner by utilizing trainings that are free of charge or have a very minimal cost for nationally recognized organizations. One of the concerns expressed by the industry when requiring trainings is the associated cost, and so we'll work to alleviate that concern, and we believe that the way the bill is written does that. In addition, by utilizing trainings from nationally recognized organizations that provide evidence-based practices, such as the Centers for Disease Control and Prevention, it allows individuals to access training online, making it much more easily accessible. This concludes my testimony, and I'm happy to answer any questions. Thank you for the opportunity again.
Thank you, Ms. Chappell. And I believe, do we have any additional presenters, Assemblywoman Cohen?
No, we don't, unless there's anyone else who's okay. No, we're ready for questions.
Perfect. I will start with Assemblywoman Titus.
Thank you, Madam Chair, and thank you both Assemblywoman Cohen and Margot Chappell for the presentation in the bill. It was certainly something that came of light with our pandemic. There's two things, a comment. I'm glad, thank you that you looked to the cost of this and making sure that these would be available at no additional cost. My question revolves around, I just need some clarification that the penalties and fines for not doing this under this chapter and looking at the bill under section 2, section 3, number 4, those penalties are actually already in existence. So this isn't a new penalty or any new fees. It's just, these are already penalties for not following through on this workplace safety. And I just want that clarification on the record.
Margot Chappell, for the record, yes, I confirm you are accurate in your assessment.
All right, great, thank you. And that's really my only question, and thank you for bringing this bill forward. As I said on that committee also, and it was a notable void that we have. And I like the wording that it's open enough as things change in the infectious disease, healthcare world, we can change with them, and it doesn't always require a new statute. So thank you for that, and thank you, Madam Chair, for the question.
No problem. Thank you. And next up, we can go to Assemblywoman Summers Armstrong.
Thank you, Madam Chair. Thank you, Assemblywoman Cohen, for bringing this forward. I just am a little confused, and not confused, but I'm just trying to make a connection. So when I don't work in the healthcare field, but I know that where I do work, there's required OSHA training already that talks about cleanliness, disease control, how to deal with separating clean and dirty articles when someone's cleaning a bathroom or a public facility. Can you tell me how this is different from OSHA training and why it's different? And then I have a
It is different in terms of that they might take the same training if it's from the same source. However, OSHA doesn't necessarily go into our facilities. We regulate them 100%, and unless we have a specific issue related to something that OSHA manages or oversees, then we send them a complaint as well. But generally speaking, we're responsible as the regulating agency for all of that in those healthcare facilities. Please let me know if that doesn't answer your question. I'd be happy to expand on that more.
Thank you, Madam Chair. Follow up, please.
Go ahead, Assemblywoman.
Thank you. My next question would be the cost of training. You said free or very inexpensive training is available. My concern would be whether or not any of this training would then, the cost for it would be expected for the employees or contractors. And I say contractors because some of the facilities may have people who are I-999 or whatever you call that, that don't work for large corporations, but are small independent contractors or even individuals who have found a little niche to be able to do this type of work. How do you control that? And the second part of that would be, why isn't this expanded to those who go into people's homes as home health care workers? And my question about cost and that being the responsibility of the employee would also be the same. How do you control and ensure that these employees, who generally are not making that much money, don't end up having to absorb costs? Thank you very much.
Thank you, Margot Chappell, again for the record. Through you, Chair Wynn, to Assemblywoman Armstrong. So there are separate regulations that govern training requirements for personal care agency staff and home health care staff that you're talking about. We actually have cited a couple of personal care agencies for not providing the training at no cost to their staff. So that's addressed in regulation already. And we can certainly, when we go to develop regulations, we can add something like that into this, into the regulation as well.
Madam Chair, may I? The other portion, the first part of the question was regarding those who might be subcontractors at these care facilities. Is there any way to make sure that they're not having to absorb that cost? Thank you.
Again, Margot Chappell, for the record, we can add that into the regulations when we start drafting them. Thank you.
Thank you. And I have a question. Is it my understanding in reading this that the facilities that would be covered or subject to this is anything licensed by the state division? Is that correct?
Margot Chappell, for the record, that is accurate.
And I'm looking around here. Do we have any other people that have any questions? I'm looking at my chat here. I see Assemblywoman Benitez Thompson, if we can go to her next.
Thank you so much. Sorry, I'm moving a little bit slow today, but I appreciate, thank you so much. I'm moving a little bit slow today and clicking through the screens. I did want to clarify that last piece because I think when I want to make sure, so when I look at the bill, the 44, I think specifically it's 44029 through 442428 are the licensing facilities that we're talking about, right? So that's typically, oh gosh, I was just pulling up the statute to look at it, but I think there was a distinction between the ones licensed for the state, and I saw in there like supportive living arrangements. I think any of your hospices are in there. The independent center hospital is in there. Homes for individual residential care are in there. Halfway houses are in there. Am I right in looking at that list of defined medical facilities as the ones being included or the
Yes, to my Margot Chappell, for the record, to my knowledge, correct.
And Assemblywoman Benitez Thompson, I can also have our legal follow up with that to confirm that those are the people that are located in it if you need me to.
No, I appreciate that. I just want to make sure, because sometimes when we talk about defined medical facilities, it can be different than what we think about. I think there's only 2 carve outs in the medical facilities. I can't remember specifically what they were, but I think generally they cover, like, we might not necessarily think of halfway houses as a licensed medical facility or transitional living as a licensed medical facility. I just want to make sure that the statute covers all of that. So that was the intent as well.
Perfect. Thank you. Do we have any other questions from committee members? Seeing none, I will ask Broadcast Services to get ready to take callers from our public line in support, opposition, and neutral of Assembly Bill 217. Again, I will remind everyone to clearly state your name, spell it for the record, and limit your testimony to 2 minutes so everyone is given a fair opportunity to speak. And with that, we will begin testimony in support of Assembly Bill 217.
To testify in support of Assembly Bill 217, please press star 9 now to take your place in the queue. Would the caller with the last 3 digits, 528, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair, members of the committee. For the record, my name is still Barry Gold, B-A-R-R-Y-G-O-L-D, and I'm still the Director of Government Relations for AARP Nevada. I'm very familiar with this bill and the history. I can remember in the 2017 session, I believe it was, sitting in Assemblywoman Cohen's office and talking about this. And there was a discussion, lengthy discussion among all the stakeholders about which facilities, which staff, what specific training, who was going to track it, and who was going to actually do the training. Some of the early discussions were, well, all this training will be done by a registered nurse. Well, that's terribly problematic because we don't have enough nurses to take care of people in facilities, let alone do all this training. So there's been several studies, as indicated before, talking about the who, what, where, when, how, and why. And that's really fabulous. Looking at this bill, this really allows the department to really look at a lot of those decisions, to look at which facilities we are talking about. We're not talking about the skilled staff in nursing homes or in hospitals. We're talking about these other places where we do have staff that do provide some level of care, who we really are unsure what, if any, training that they're receiving. So that's really important. Something that I said back then in 2017, and I'll say again in a hearing, I'll repeat it, is I said that Nevada sometimes is very good in some of these types of facilities as we fingerprint people, we do background checks at people, and we do fingerprinting, we do background checks, and we do TB tests on people. But sometimes we don't do a whole lot more of that. And so we really need to make sure that these people, if your mom or your dad or my father or my grandma were to go into one of these facilities, we would be comfortable knowing that the people that were going to help take care of them had some basic level of training on some basic care qualities and things like that. So this bill is really fabulous in terms of allowing those decisions, and there was a lot of talk with stakeholders about the best way to do this, to allow that to be done through regulations, to really pinpoint who needs to get it, where these people are, and what those specific topics are. So for those reasons, AARP, on behalf of our 345,000 members all across the state, support this bill and urge the committee to pass it. Thank you very much.
Thank you, Mr. Gold. If we can go to our next caller in support.
Chair, there are no more callers in support at this time.
Thank you. If we can go to callers in opposition of Assembly Bill 217.
To testify in opposition of Assembly Bill 217, please press star 9 now to take your place in the queue. Would the caller with the last 3 digits, 754, please slowly state and spell your name for the record. You have 2 minutes and may begin. Would the caller with the last 3 digits, 754, Please press star 6 now to unmute yourself. You have 2 minutes and may begin.
Hello, Chair Wynn, members of the committee. For the record, this is Brett Salmon, BRETTSALMON, President of the Nevada Healthcare Association and the Nevada Center for Assisted Living. Appreciate the opportunity to share our concerns with Assembly Bill 217. Some of them have been kind of addressed already, but I just want to hit them and get them on the record, and then maybe I'll have the opportunity, or I hope to have the opportunity to talk a little bit offline about them. Obviously, we're very supportive of improving the quality of care in assisted living and my nursing facility membership. And we've been fighting COVID like everyone else in the last year, and have had lots of tough times, but also had lots of successes with infection control. Frankly, we have one of the lowest COVID death rates in the country in long-term care. And so, fortunately, my members have done a really good job with regards to infection control, and we appreciate all of their efforts. As to AB 217, we feel like it would be nice to have a little more clarity as to who those unlicensed employees really are, and how that would apply with the term provide care. It said unlicensed caregivers who provide care. Maybe sussing that out a little bit as to what provide care means. The next point that I wanted to raise was we were hoping for clarification on the definition of the designated facility. You've all sort of spoken to this issue in advance of this, but designated facility is very broad to us, and we would like a little bit of clarity as to the facilities that are included in it. If it's all of them, then that's good to know. The way that it's written now, the designated facility language just makes it a little bit confusing to us. And then the bill, on the training aspect of the bill, obviously cost is a factor. If there's free training, that's wonderful, and we hope that'll be the case with this legislation. But it's a cost for employees. When you train employees, there's always a cost involved because of the time factor. And so we would like to know sort of a little bit more about the length of the training that it is being hoped for in this legislation. And then if the annual training is just related to general cleanliness and sanitation, like sort of a restaurant style training, or if it's a CDC training for unlicensed caregivers in a non-medical facility, that causes us a little bit of concern as well on the standard of care. And so we would like to maybe understand a little bit more of the intentions of this in relation
Salmon,
to that.
you were at 2 minutes. So if I can ask you to wrap it up, and I would encourage you to reach out to the bill sponsor as well as the other committee members to follow up with some of your concerns, so hopefully we can address those.
Great. Thank you for your time.
Thank you. And if we can go to the next caller in opposition.
Chair, there are no more callers in opposition at this time.
Do we have any callers in neutral?
To testify in neutral of Assembly Bill 217, please press star 9 now to take your place in the queue. Would the caller with the last 3 digits, 020, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Madam Chair and members of the committee, my name is Jim Wadhams, Wadhams. I'm here today speaking in the neutral position on behalf of the Nevada Hospital Association. We have followed the work of the interim committee in this regard, and believe we understand the intent of this legislation and are neutral to it. As the committee may well know, hospitals are already covered under a similar law, which is found at NRS 449A.300 through 330. That was adopted in 2015, dealing with caregivers. We would be happy to work with any of the other stakeholders as this bill progresses, and would appreciate being kept on any list of that opportunity. Again, though, we are in neutral, and thank you for the time.
Thank you for your testimony in neutral. Do we have any other callers in neutral?
Would the caller with the last 3 digits, 237, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Wynn and members of the committee. My name is Marlene Lockard, Lockard, representing SEIU 1107 and 13,000 personal care aides who care for elderly and disabled Nevadans. We are in support of this bill, but under the rules, we are offering an amendment and so are testifying in neutral. We have become aware of an industry-wide problem wherein personal care agencies are requiring PCAs, personal care aides, to pay for their own annual training. This practice is both very atypical in the home care industry nationally and not supported by Nevada statutes and regulations. Personal care agency licensing regulations, specifically NAC 449.3975 and NAC 449.3977, describe the 8 hours of annual training that PCAs are required to receive. NRS 449.3973-2A states that the administrator of an agency is responsible for employing qualified personnel and arranging for their training. Furthermore, NRS 449.093, subsections 5 and 7, specify that employees of personal care agencies must receive training to recognize and prevent the abuse of older persons before the employee provides care to a person in the facility, agency, or home of older persons before the employee provides care to a person in the facility, agency, or home, and annually thereafter. And that the agency is responsible for the cost related to the training required by this section. We recently conducted a survey of PCAs and found that almost 70% of PCAs reported that they have to pay for their own training. An equal portion of PCAs reported difficulty affording paying for the training. Not surprising.
Ms. Lockhart, can I get you to wrap up? You are at 2 minutes right now, and just in the interest of fairness and consistency. I know that you have an amendment. I believe it has been posted on Nellis.
Yes, that's okay, to just wrap up, for an industry that receives a median wage of only $11.07 an hour, and that's at a time when the Gwynn Center is estimating we're going to need an additional 5,300 personal care aides. So I urge your support of my amendment for SEIU's amendment to this bill, and I'd be happy to answer any questions.
And Ms. Lockhart, at this time, we were doing testimony in neutral. So based on our committee rules and the testimony that you presented, it looks like you are adding support of the amendment that isn't currently on the table. So I'm going to recategorize your testimony as opposition testimony, and I would encourage you to reach out to the bill sponsor as we move forward through processing this piece of legislation. Thank you for your testimony. Do we have any other callers in neutral broadcast services?
Yes, with the caller with the last 3 digits, 717, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, for the record, I'm Connie McMullen, CONNIE, MCMULLEN, representing the Personal Care Association of Nevada on AB 217. PCAN is not opposed to caregivers receiving more training, especially in the areas of infection control. Currently, state law requires caregivers have training before they can even step foot in one's home. This area does involve infection control and many other areas of importance. Having said that, this is an area where the scope of training and skills taught should not be a hardship to do so. Last session, the much-needed cultural competency training was put into regulation. This year, health facilities are trying to meet that mandate, but the only course being offered that meets the criteria is 9 hours and $100 a person. In the bill, hours of such training was never even addressed. We have similar concerns with the language as this bill. PCAN is not opposed to more training, but the scope of the information must be reasonable in application in these difficult times. We thank you for your consideration of our testimony, and on behalf of some 30 companies that I represent, I do not realize or have any information as to what Ms. Lockhart was talking about, but I would be happy to address it. Thank you very much.
Just to clarify, was your testimony in neutral of the bill, or are you in opposition of the bill as it currently stands?
I'm in neutral. I need more clarification as to the way the bill was written. I don't think it's specific enough. And I hope that helps.
Thank you for your testimony. I would just encourage you to again reach out to the bill sponsor regarding any questions you have the language. It appears that you have some concerns with the language as it has been currently presented. So at this time, I will probably likely recategorize your testimony as opposition under our committee rules. Do we have any other people testifying in neutral on Assembly Bill 217?
Chair, there are no more callers at this time.
And do we have anyone on the Zoom that is testifying in neutral on this bill as well? I don't see anyone at this time. I will turn this back over to Assemblywoman Cohen for any closing remarks.
Thank you, Chair. And if it's all right, I'll just make sure if Deputy Director Chappell has any final things she wants to say first.
No, that would be fine. Ms. Chappell?
Good afternoon, Margot Chappell for the record. I would just, the only thing I'd like to say in closing is that a lot of the issues that were brought up related to this bill can be addressed during the regulatory process and generally are. For example, I did get some clarification on my end that we are considering Section 1A, making it applicable to all facilities designated in the regulations, including medical dependent care and others without statutory definitions, pursuant to 499.0303, which is every facility we license. However, the regulations will designate the types of facilities to which the training requirements apply and the other details that were brought up during testimony. So thank you very much.
Thank you, Chair, and thank you, Committee, for hearing the bill. Assemblywoman Leslie Cohen, Assembly District 29. Just a couple of things I want to touch on. This bill's kind of gone on for a while, and we've kind of addressed the same issues each session. We've talked about cost. We've talked about who's included. And when we started, in my mind, because I didn't think about infectious diseases so much, we talked about how people's lives are affected when they live in these facilities. So like the fact if you've got someone untrained, if you're a senior and you've got someone untrained who's taking you in and out of the bath, you can be injured. Obviously, that's still part of the issue. That's still part of the bill. But in the meantime, since we first started, we had the pandemic, and we've seen that infectious disease is a big issue for all of us and in all aspects of our life, and especially in trying to protect Nevada's most vulnerable citizens. Again, we've been doing this for several years now, or a couple of sessions, and we keep hearing these same concerns that we are going to be able to address now in the regulations, because it will have more flexibility than what we have in statute. And with that, I'll just remind you that we're talking about individuals who are responsible for caring for some of Nevada's most vulnerable citizens, and they often receive little to no training. As far as cost, that can be addressed in regulations, as I said, like everything else. but I think we have to kind of pull the trigger. We have to get this moving and get these issues addressed and not keep pushing them, punting them, you know. And with that, I will leave it at that, except I am open to discuss this with anyone who's interested. However, I will remind the committee this is an interim committee bill. So if there are amendments, that type of thing, it's not really my place to accept amendments or reject amendments. But certainly I will talk to anyone who wants to discuss it and leave it to the committee to decide if they would like to accept any of the amendments. Thank you.
Thank you. And with that, I will close the hearing and testimony on Assembly Bill 217. I will also encourage our members, you can always go back. I believe that our policy analyst, Patrick, had previously sent out a link regarding some of the interim work that has been worked on this particular bill that came out of that interim committee work. So please review that if you have any further questions about the intent and what kind of work went into the drafting of this particular bill. Additionally, before that, now we will move to public comment. Again, I will remind everyone to clearly state your name and spell your name and limit your comments to 2 minutes. Again, we will be timing and I will cut you off if you are going over, but I would encourage you to also submit anything that you have in writing, anything related to the bills within 48 hours, and public comment can always be submitted in writing. And I know that we have very conscientious members that will review all of that documentation as well. Broadcast services, do we have anyone on the line to speak on public comment?
If you would like to participate in public comment, please press *9 now to take your place in the queue. Chair, the public line is open and working, but there are no callers to speak at this time.
Thank you for that update. At this time, are there any comments from members before we adjourn? No. Before we adjourn, I'll just give you a little update. Our next meeting is on Wednesday, March 17th. If you take a look at the agenda, it is very optimistic. You know, deadlines are coming up, even though some of the bill draft requests are still trickling in. We still have to hear them before something happens, before other deadlines occur. We do have 3 bills. Several of them are from, one of them is from an interim. It actually is work that was done in the 2019 session. I am having our policy analyst send you a link to that. So if you do want to be prepared for that, we do have a comprehensive work session that is also on deck. So I did send out an email. I would encourage members, if you have any questions, to reach out to those bill sponsors or committee staff to answer any of those questions. It will make it a much smoother process if we can do that. Like I said, I do have a pretty optimistic agenda. I do plan on hearing potentially two bills on Friday afternoon. And so please pay attention to the agendas that are forthcoming, because it does look like we will have a committee hearing for HHS on Friday afternoon. I am aware that there are limited flights on Friday afternoon for those that are traveling back to Southern Nevada. So I will be conscientious of our time and time management on that Friday meeting date. And with that, I will end the meeting and adjourn the meeting. Take care, everyone.